Okay, so we're going to go back to the tricuspid session. Neil Pham's going to take over as moderator, but I'll introduce Becky Hahn from Columbia. She's done so much fantastic work, both in mitral and tricuspid imaging and leading these trials. And so she's going to talk to us about advances in imaging for tricuspid valve interventions.
Great,
Thanks, Becky.
This is a very shortened version of a talk that I usually give, so feel free to ask questions as I go through this. But again, you've already seen some of the advanced imaging that we end up performing. And some of the issue for the tricuspid valve is that it's clearly more difficult to image. People used to complain to me that it was very difficult to image, and I was, very haughty about the whole thing, said it was not that difficult. It's always difficult to image the tricuspid. It is the far field for us by transesophageal imaging. The leaflets are extraordinarily thin, just a fraction of the thickness of the mitral valve. And it obviously sits canted from our probe. So unlike the mitral valve, where we have the probe behind the dome of the left atrium, we're always going to be approaching the tricuspid valve from the side. And therefore, we're using a mixture of axial and lateral resolution, which the lateral resolution is never good. So we need to understand, obviously, where we are and how we're approaching the valve, and try to do our best as far as reducing those pitfalls. And so one of the things that we do is when we see that we have a horizontal lie of the heart, which is on the top row, then we'll put a pressure bag, an empty pressure bag, underneath the right shoulder, blow it up, and allow the patient's chest to be rolled into a lateral decubitus position. And so that right shoulder roll does end up giving us a slightly better, more vertical view of the tricuspid annular plane and the tricuspid leaflets, and that ends up helping us a little bit. And so we almost always do a shoulder roll. Now, when you're doing TEER devices and you want to decrease the gaps during the procedure, frequently, obviously, we bring them in and we'll prehab them. But if you want to reduce the gaps, then we like to do maneuvers inside the procedure. Jörg Hausleiter has pioneered the reverse Trendelenburg that you see on the right-hand side of the screen. And we like and have published already on use of the Valsalva as well as PEEP in order to reduce the preload and therefore the gaps. So this works extraordinarily well for us. Now, the other thing that you have to realize is the echo-fluoro relationship. So you saw Gilbert just now for the mitral side rotating around to try and get a good view of the device and understand the device orientation. But really, we have three-dimensional echo, and we just need to be able to understand its relationship to the fluoroscopic image that you have. And so remember, the echocardiographer will take the heart and make the heart the center of reference for us. And therefore, our goal is to try and verticalize that heart to get the anatomy of interest in the middle of our imaging plane, whereas the interventionalist obviously is left with the patient lying on their back and primarily AP-ish views. And therefore, the echofluorofusion we found has allowed us to communicate a little bit better with our interventionalists. Now, the other thing we learned was that the tricuspid valve is very close to the diaphragm. It's the most anterior valve of all the valves in the heart, and that's why we have difficulty from mid-esophageal views. But as you move deeper toward the stomach, then the tricuspid valve now becomes the near field valve. And so therefore, the deep esophageal view was added to our screening echocardiography, TEE guidelines in order to optimize tricuspid valve imaging. So you see here again the four main planes that we use for tricuspid valve imaging, which include the mid-esophageal view. We love the inflow-outflow and using biplane and 3D, live 3D. But the deep esophageal view allows us to get the left heart out of the plane of our image and image directly onto the tricuspid valve. In addition, the transgastric views, as you'll see later on, become very important for us as well, because it is the only view where on two-dimensional imaging you can see all three leaflets at the same time, or three or more leaflets at the same time. So you're able to see the short axis of the valve. And then we like our deep transgastric views because this is where we do most of our Doppler, given the alignment of the insonation beam. So again, these are examples of both the mid and the deep esophageal view. You see on echofluorofusion the orientation of the fluoro image in the red circle, and then the orientation of the echo probe in the blue. And so those mid-esophageal views, again, we're doing a sweep of the inflow-outflow view, which allows us to now sweep across the septal coaptation zone. And so this is one of our favorite views for characterizing the location of the jet and guiding where the initial devices should go. And then as you can see here, hopefully, I guess it's not playing, but you can actually see now from a deep esophageal view, how we've now eliminated the left heart from the view, and therefore the tricuspid valve is now in the near field, giving us excellent imaging, and we can again sweep across that valve and characterize the regurgitant jet. Now, the transgastric views is, as I told you, the only two-dimensional image that will allow you to get the leaflets in short axis, which then allow you to characterize the number of leaflets, and also is the view that we like to look at to reorient our device arms. And so this assures us that we have the orientation that we desire in order to get, obviously, an adequate reduction. Now, from the transgastric views, you can easily do a 3D reconstruction, and again, confirm the leaflet grasp as well as the tissue bridge. And so this is transgastric views that allow us to do almost the complete device imaging if we need to. We don't prefer to do it from the deep esophageal. From the transgastric, I mean. All right, so these are the probe positions for the deep. You can see how far deep we are, and we're angled anterior to as if it were a transapical view, but does allow us to align our insination beam. Remember that the biggest lesson for us was that three-dimensional imaging is our friend, and that from any of the views, mid-esophageal, distal esophageal, shallow transgastric, or deep transgastric, we can reconstruct the image in any way that we want in order to communicate with our interventionalists the same way every time. So it doesn't matter if we have acquired it from a mid-esophageal or a transgastric view. We will typically reorient the imaging plane so that we have the posterior, anterior, septal, lateral moving across our biplane image. And then we also know that we can reorient the orthogonal view. It no longer has to be 90 degrees. This is just a gift from our ultrasound company, so in order to align our device arms perfectly for a two-dimensional grasp. But what we really love is if the image is good on 3D, that we'll do the entire case using 3D multiplanar reconstruction. So this is indeed different patients' imaging using 3D multiplanar reconstruction from a mid-esophageal, deep esophageal, and transgastric view in order to show that you can reconstruct in the same way every time and speak to your interventionalists much more smoothly. Now, TTVR is a different device. This is obviously an Evoke device. This was just CE marked about 2-3 weeks ago. And this is a device that you have to image all 9 anchors positioned at the annular plane with the leaflets falling above. And so you can see here in the cartoon that that's exactly what the goal of the imaging is, and this is where multiplanar reconstruction is absolutely key. We don't need multiple imaging views for this particular device. Raj Makar told me that he put one in 12 minutes. I don't know, that should be a record, I think. Our shortest was 28 minutes, so I don't know how he got it in 12, but I mean, it's like amazing. But it's because we have multiplanar reconstruction. And so you can do this spin, and as long as you're keeping track of the leaflets as you're spinning around and looking at each of the 9 anchors, then you can do it relatively quickly, and you can get the device deployed very safely. So this, again, is the Evoke device. We haven't moved. We don't move almost the entire case if we have a good imaging view from any plane. The advantage to us in the U.S. is that we have 3D echo probes now available. So this is 3D ICE echo probe, sorry. So this is 3D intracardiac probe doing a Pascal. And we've positioned it here right behind the device because we had a little bit of difficulty imaging leaflets well. And so this is the home view for us, which is the inflow-outflow view. And from here, we can then perform the procedure, the leaflet grasping. But we like to have both the TEE and the ICE probe in place because, again, the wider field of view of the TEE probe allows us to orient the device well from transgastric views. So you can see that the ICE probe is this little device here, and this is obviously the Pascal device. And so with the ICE probe, we can actually, on three-dimensional imaging by TEE, guide the positioning of the ICE probe. And that's what we like to do from this bicable live 3D view. And so after we've done that, then we'll go ahead and park our esophageal probe in the transgastric view. So now we don't have to pull in and out. We can just leave it in the transgastric to allow us to align our device at all times or really understand the alignment, and then use the ICE. So this is the 3D ICE probe imaging where you can see every part of the device and the leaflets and the leaflet grasp. And so this allows us then to keep one probe in the transgastric and then the ICE probe in the mid-right atrial view. This is the final result. You can see it's a trivial amount of tricuspid regurgitation. We've taken it from massive to trace. You saw on the ICE image that the regurgitation always looks a little bit more because it's very, very near field, and there's a lot of blooming artifact from the device. But this is the actual final result. It's just a beautiful result from using concomitant ICE and TEE. But what's the future of imaging is, as usual, miniaturization. This is, you've seen the ICE probe, but what we like to show is that we will soon have the mini or small caliber TEE probe, and this is a matrix probe. So I'm going to have you vote. Which side do you think is the regular probe? Who votes for the left? You guys got to vote. And who thinks that the large probe is on the right? All right, so some of you vote, okay. Well, it turns out that the large probe is on the left. So this is the capability of the X11-4T, which hopefully will become 510K approved in the near future. It is not available commercially right now. This was one of our patients that we had to get IRB approval to test out the probe. But you can see very clearly that this is different crystal engineering as well. This is not the same piezoelectric crystals, and that's why in a tiny little mini TEE probe, you're able to get image quality like this. And so we do believe that we will have the ability to use the mini TEE probes possibly without general anesthesia. That remains to be seen. And then the other advance for us is the holoscope. We have the first one in the United States up at Columbia. Feel free to come up and see it. It's just absolutely hysterical because there's actually a 3D heart sitting in front of you. And this is all based on 3D echo. And so this was the first device that was implanted, Watchman device that was implanted using holography. And then we've gone on to do about almost 40 cases now with a combination of left atrial appendage closures, paravalvular leaks, and mitral clips. And so again, this is a possible new device that allows the interventionalist to have some control over the three-dimensional imaging by having it right in front of them. Again, able to manipulate using voice control. So it's, you just tell the holoscope to crop, and you can crop in with your finger, and it's quite an amazing device. So the overcoming challenges, the tips are to use positioning as well as any other tool to enhance your imaging, to use all four main levels, but particularly use three-dimensional imaging on those 4 levels. Remember that 3D ICE is for tricuspid valve disease is going to be a real game changer and make the procedure much more accurate, much more precise, and the communication much better in the lab. And then embrace the future, because we have a lot more devices and modalities that are coming. Thanks for your attention.